believe it or not, I had about 14 hot flushes a day, going from about 3 to 5 minutes with sweat. And then I asked Dr. Montgomery's nurse practitioner about what should I do to reduce that, and she gave me FHCRC. That is helping. It has reduced hot flushes. But if you might share with us what your experiences are with these hot flushes and how often you get it, and what she did for me was get one of these battery-operated fans that in my office, in the family room, in the bedroom, and then I just turned it on and pulled in a apartment we'll be done.
Would you mind repeating the question?
The whole question? The question he asked was, well, firstly, how many thought flashes he had in an hour, a minute, or a day, and then the second was what to do. I get maybe, and I can't answer that because I maybe get during the wintertime, and if the room's temperature, I'm working outside or something, and during the night I don't get any. In the summertime, I may get 1 or 2 in a week, and they last for a minute, maybe 2 minutes, and that's about it. I've just been very fortunate. I haven't had any of those kind of side effects. For what you to do for you, I can't tell you what to do. No.
14 times a day.
I think Dr. Lang has a question.
We're talking about the studies. Let me just give you a little. I just thought of this when I was listening to you. I can still remember when I first started medicine, or I got interested in cancer, and they were just poised to start many, many trials in children where the death rate from their cancer was almost inevitable. And I can still remember people saying, oh, these parents will never let their children engage in these randomized trials or whatever. And they were dead wrong. And the rate was well over 90% of the parents engaged their kids in these trials. And the other thing, and the thing that they got across, among other things, because everybody says, well, what's in it for me? Or what's in it for my child? But the other thing that came across very well, and it comes across in many cancers, and prostate has not been as good as it should have been, is patient as hero. And that is that there was this culture where we were engaged in trials not only to benefit personally, but because they were part of a larger scene, which was to actually benefit all patients and mankind in general. And the pediatric experience was a classic example of that. And now, as you all know, a vast majority of the pediatric cancers now are curable.
So we've got about 5 more minutes. We've got about 5 more minutes, and I just want to open it up to more broad questions, see if you have any for Dr. Masagal or Dr. Chang or Dr. Montgomery or anyone else about anything we've talked about. There's a question in the back. You just...
If you have too much testosterone, your cancer increases. That's how I think I heard it. And you're going to block the testosterone with one drug or another to reduce the volume of testosterone in your blood. That which, in my thinking, the sexual drive will be reduced to much less than 0. I think.
Yeah, so certainly it has become the standard of care for advanced prostate cancer to suppress testosterone, to lower the blood level to basically as low as you can go. And that produces responses, i.e. cancer shrinkage, improvement in pain, other symptoms in more than 90% of men. The problem is that that's not a cure. And it also clearly has side effects. It does reduce sexual function, it reduces muscle mass, it reduces bone density, etc. But it is the most effective treatment initially for men whose cancers has spread. The problem is it's not a cure, and what Dr. Mostigel mentioned and discussed are ways that the tumor becomes resistant to lowering blood levels of testosterone, and 2 new drugs approved over the last several years that continue to hit that pathway have extended survival. Again, not cures, unfortunately. So the question is, how can we do a more effective job at blocking that pathway?
My doctor says, because some conversation we just had last week, don't worry about that, the testosterone isn't the issue, so I'm confused.
Well, it depends on what stage. So you have a lot of details, and that's what's difficult to discuss in an open forum, is that everyone's cancer is different. You're approaching, at different stages in your disease. So it is important to have a very detailed discussion with your physician and get second opinions regarding best option and things. So can't give you too much more specialized advice for that. Other question in the back?
I'm on the blueprint, but I was told by my doctor that say you think, well, I'll just keep taking this all the time, and I'll just, he said that can, it can become immune and mutates, and so therefore it can eventually maybe do nothing for you.
It is true that the prostate cancer clearly evolves over time, and it evolves in many ways to eventually become resistant. One mechanism is that engine becomes amplified, the androgen receptor itself. Another mechanism that Dr. Mostigel mentioned, there is a mutation that occurs. These cancers have this ability to continually evolve. It's an arms race. It truly is. And there are very few men, I couldn't say zero, but very few that are truly cured simply by suppressing blood levels of testosterone. The usual scenario, it's about 3 to 4 years, and then the PSA starts going up again. So you're exactly right. The problem is we don't have yet better therapies up front that are better than suppressing testosterone. Okay. Way in the back.
I wanted you to talk about some of the current trials that are available and what some of the requirements are for them.
You want to address that? Maybe we can focalize that. Do you mean an advanced prostate cancer? We have. Okay.
Right. So the question was, can you talk about what studies are available in advanced prostate cancer? So. As I think you heard a little bit about from a number of the speakers, what we're trying to do is to optimize the combinations. So in folks who have a cancer that isn't responding to Lupron, we have a study in which abiraterone is combined with this PARP inhibitor to try and better target these mutated cancers that have what's called the T2-ERG mutation. So that study is open at the University of Washington. There is a study of what's called pharmacodynamic abiraterone, where patients actually we're looking at what determines response and resistance to abiraterone, and as part of that therapy, the abiraterone dose can actually be doubled because there's some suggestion that actually more drug may be important in fighting cancer later in the process. There's this drug GTX, which is an estrogen receptor agonist. All these studies are available to patients who have cancer that is metastatic, but they have a rising PSA or evidence of progression on scans, but most of them are not having a lot in the way of symptoms. So that is a small subset of the patients, or of the studies, and there actually are, there's a website that has all the different studies on it through the SCCA, which is probably a better place. I'm actually happy to talk to you after the symposium to sort of get a better sense of what you may be interested in that is specific to the situation that you're dealing with, because literally there are 15 different studies. So I think, and they really are appropriate for very specific folks. So I'd be happy to talk afterwards with you about the details. Okay.
So we'll all stick around here. I want to, in the interest of time, just so that we promised we'd be done at 2:30. It's 2:32, so we're going to wrap up, but we'll all stay here to answer questions. So just to reiterate, we will post all these talks on YouTube, so you'll have access to them. I think most of you were given a a comment sheet to provide feedback. We want this to be useful to you. And so as we do this again, certainly a year from now, maybe even 6 months from now, if there's additional topics that you want to have on the agenda, if you want more detail about some, if you feel that some are clearly addressed and you don't need to hear about them again, let us know. So this feedback is really critical. For any of you that want to get involved in the IPCR and this Act Smart program, please go to the website and contact the individuals that are listed there. And then I'll put in one final plug. So the Fred Hutchinson Cancer Center has an event called Obliteride, that is obliterating cancer. We had our first event this last summer, and the prostate group was the top fundraising group, and all those funds go right into prostate cancer research. It's going to be this next August, and Dr. Lang actually was the top fundraiser last year and had an epic bicycle ride. So for those of you that want to join our team, we do have a team IPCR here that'll be riding for this cure. So
What would be the YouTube search parameters?
we'll put that, so that website where you all registered for the symposium, we'll put the YouTube link for all the talks on that site to make it easy. Otherwise, we'll probably call it something like Prostate Symposium 2014 if you Google it, IPCR 2014. So you could probably Google that, but we'll try to have the link for all the talks on the website where you registered as well. So give those to NOLA on your way out, and thank you all for coming.